very glad to have you with us. So I'm going to introduce myself and the speakers. We'll give you a bit of an introduction to our conversation topic today, and then we will move directly into a panel style discussion where we're batting around this topic around, as we've got on the screen here, transforming real estate and patient care with a specific focus on addressing care for children with long-term conditions. So my name's Alex Harvey and I'm VP of Sales with SpaceStore, and very excited to be joined by other panelists today who'll give a brief introduction to themselves. So Steve Levers and Shane Barry. So Steve, do you want to give us a quick introduction to yourself and your background?
Yeah, sure. Hi, I'm Steve Levers. My background is nursing. So I'm qualified nurse, been a director of nursing, chief nurse, worked at executive level in the NHS in a number of trusts. Also for the last 15 years, I've been a turnaround director in the NHS, working with trusts in both financial special measures and quality special measures.
Great, thanks Steve. Glad to have you with us. And Shane?
Yeah, thanks Alex. Good to be on this webinar. So I'm a concept advisor here at SpaceStore Healthcare and been working on journeys with many NHS trusts on how we can help them in their transformation of outpatients with our product of SpaceStore pods. Thank you.
Good, thanks Shane. And as I mentioned, my name's Alex Harvey. I'm VP of Sales here with SpaceStore. My role spans both our workspace divisions, and we'll talk a little bit about the background to SpaceStore in a second or two, as well as the healthcare division, where we're working with not just NHS trusts but other healthcare providers, although a big proportion of that is the NHS trusts nationally, around how we can help embrace the change that's happened during the pandemic and as a result of the pandemic because of VC, virtual consultation. Not just embrace what has happened, but also to hold on to the gains that have been made, which for many trusts is a key driver right now. So we're excited to have you with us today, and the conversation really is focusing around how we can address the care needs for patients, particularly in the education sector, with long-term conditions. But maybe to give some context to SpaceStore's viewpoint on this, it would be helpful to understand who SpaceStore are and what SpaceStore actually do on a day-to-day basis. So SpaceStore have been creating modular workplace furniture for nearly 30 years now. Our furniture is a blend of California cool and London design, and what that really means is the clients that we work with, particularly focusing in the corporate sector, have been either as a result of our background here in London, our roots and heritage, or more recently in the last 10 years, we've also been working with many clients, particularly starting off with Silicon Valley and the tech companies in Silicon Valley, but we've been working with many clients in the tech sector who have changed how real estate and how the real estate workplace is both viewed and used. And a big part of that has been the modular pods that SpaceStore have created. So these are enclosed acoustic, plug and play acoustic environments where you could go for a telephone or a video conversation, to be either, we see kind of the use case in both ways. So either you could go there to have a private conversation, which is kept confidential, I should say. So you're protecting that conversation and ensuring privacy. Or in some cases, and with some clients, it's ensuring that that conversation, particularly if somebody's on a Teams or a video call, isn't distracting and disturbing the other users of the open plan space around you. Because we've all seen that situation where somebody's in an open plan space with a pair of noise cancelling headphones on, and actually they're distracting and disturbing the focus of the other users of the open plan space around you. Now, what we've seen is, as I say, as a result of the pandemic, the use of VC in healthcare has massively increased. And during the early part of 2020, we started hearing many NHS trusts coming to us at SpaceStore saying, we need more space to have these video conversations and these telephone conversations that's private, that respects patient dignity and privacy, but also that is scalable rapidly, because the time taken to build new clinical rooms is going to be too slow compared to the amount of VC we need to do to support our patients' needs and to continue delivering the clinical provision that we have to be able to do. So that was really where our journey started, and I think right now it's a very apropos time. I was just actually looking at my text the other day, and I found the text on the 24th of March 2020, almost exactly 2 years ago, from the UK government saying we are now in national lockdown, stay at home, work from home. So I think we've reached a point where we've gone through that last 2 years. It's had some very significant impacts on us, on our lives, on how we live, work, learn, and also how we access healthcare. So that's really where we're at today, and we wanted to discuss a specific aspect of the impact of that, which is patients with long-term conditions, particularly those still in education. And Steve, I wondered if you could pick up at this point and just share a few of the thoughts that you've had and that we've been discussing around, what's the specific aspect that we're looking at, what are the specific pain points we're looking to address, and how might we see this playing out?
Yeah, of course. Some of the things that I'm going to say are obvious to everybody, but I think it's worth just talking about how we got to where we are. And that COVID's been tough for everybody, but it's been particularly tough for young people, children and young people. It's isolated them in a way that we've never seen before. Even World War I and World War II didn't isolate people in the way it has now. And what we've done is close down society. And that's led to a number of issues, but there's an equally well documented effect that's had on people's mental health. And those people who are in full-time education have been really badly affected by it. So their networking and core support groups have all disappeared. Their access to things like practical education has disappeared. So if you are a student of any of the sciences, then access to labs and to physical capacity has been changed. And that's had a fairly devastating effect on those young people. But within that group of young people and children, there's another subgroup, which is those people with long-term conditions, whether they be young people with mental health problems, or whether they be young people with physical problems. And one of the things that we believe that we can do with virtual consultation with the pod is to get all of the schools in our catchment areas for our trusts, whether we be primary care, secondary care or tertiary, and change the way we see those children. So we stop taking them out of school, we stop taking their parents out of work, and we stop requiring them to turn up in our facilities 5, 6, 7, even 12 times a year. And by doing that, we will improve their well-being. So just as a simple memory jog, the things that have happened is that both teaching and learning has suffered. So we think about teaching and learning as being separate, but they're joined up, and they've both changed and they've both suffered. Lots of people through 2020 in particular had all of their education via a virtual platform. People have lost time in classrooms, they've lost networking, they've had real changes in the way they do exams, and exams are building those people towards a future education. Sean circulated some stuff earlier this week that showed that from memory something like 13 or 14 trillion pounds worth of lost potential earning those people who've been through this will suffer from. So massive changes in society and in education. At the same time, the NHS has struggled. And the NHS has struggled so that waiting lists have gone up, access to healthcare has gone down, particularly access to primary healthcare has deteriorated. And many people have talked and commented on the change of access to primary healthcare. So trying to see a GP has become almost impossible. Trying to access dental services has had a similar thing. And then for young people, different from adults, there's been real safeguarding issues. And there's stuff in the media every week about what happens when safeguarding doesn't work. But safeguarding is very definitely part of core life in education and core life in healthcare. And what we need to do is to change that, to reintroduce or improve access to healthcare. We have to improve performance within the NHS and tackle waiting lists, engage with patients, with people, with service users, with parents, and dispel the myth that service users don't understand tech. I've spent most of my adult life working in the NHS, and I can't count the number of times I've been told there is no point texting, phoning, or video calling patients because they don't know how to use the tech. And I think that's a myth, and I have done for years. We need to engage more with everybody, but I'm particularly thinking about marginalised groups. And the things that marginalise people include poverty, diversity, differences in language and culture. And I think that what we're talking about here is about going into people's world and being able to engage with them so we don't lose that. One of the big challenges, I think, for education is a child or a young person with a long-term condition, whether that's physical or mental, has to lose lots of time from school. And if they lose time from school, then their parents are also losing time from work. And if those parents are either on 0 hours contracts or fixed rate contracts or hourly pay, then every time they take their child out of school, they lose money. And therefore they're reluctant to take children out of school. And we think by putting pods into schools, we will allow children to access healthcare without the parent having to travel long distances. And in some cases, lots of the bigger schools and the groups of schools have teams of safeguarding people who, with correct prep, could spend time on those video calls with the children rather than having to bring parents into school. And then we could find a way to keep parents involved. We want also to improve access to mental health services. And I looked today, just in prep for this, at the NHS website for access to mental health services. And every single reference that I looked at pointed to physical rather than virtual interaction. So it talked about meeting groups, it talked about support groups, it talked about coming in for coffee mornings, and they all talked about bringing people from their world to our world so we could address their problems. And I think there's a need to embrace video, but all virtual. So I would include within it, well, mobile as well as video, and engage with people. So that, I think, is the context of where we are. The challenge that we face. So I'm going to leave it there and hand back to Alex. And if anybody's got any questions about what I said, or if they want to challenge what I said, or add to it, indeed, then please do from the system.
That's great. Thanks, Steve. Sorry, I'm getting a bit of feedback there.
Is that a good thing or a bad thing?
Usually not good, but there's some great points you've made there, and I think really helps to kick the conversation off. So the concept we're really discussing is taking those modular pods that we spoke about earlier that Space Store have and that we've been producing with many of our corporate clients, putting those into an education setting. The intention is that we don't take that student with a long-term condition out of school for some of his or her check-ins and normal clinical interactions. Now, we understand that there's always a time when a physical interaction is necessary. And I think one of the key conversations we've had with many of the trusts we've been working with here at Space Store is understanding that those two streams need to coexist. They need to operate in parallel, and a hybrid way of connecting with the patient is actually probably a more sustainable future for healthcare generally. But if we can take the video conversations out of clinical rooms, it then frees those clinical rooms up to allow the face-to-face interaction to happen. But from the patient side, it means that we're actually removing the need for the patient to come out of school. Often, as you say, Steve, their parent would have to take half a morning off work or a morning off work to take them to the hospital, which I think could have significant impact. And we've just tried to put down a few thoughts, and as we go through today's conversation, we're going to kind of come back to this slide where we got these kind of 4 quadrants: education, social care, the NHS, and then of course most importantly the patient themselves. And we'll come back to this to help guide the conversation, but we'd love to hear your thoughts. We'd love to hear any questions you have, either via the question box on the LinkedIn live stream or the Q&A box on the Teams platform here. But I think one of the challenges we've got, and I'd love to know your thoughts on this, Steve, is that this can be viewed as a little bit of a siloed approach, and I think in the conversations we've started to have with trusts, with education, both education departments and also individual schools, this isn't any one person's problem from a public sector perspective, but it is the patient's challenge, and we need to work together across multiple different sectors to help resolve the issues that there are, and to create a better patient experience. But what are your thoughts on that, Steve? How can we open that conversation up, get beyond the siloed, or the boundaries that maybe our silos could be inflicting on us?
One of the things that I think is that describes our society, we have hospitals in smaller towns across the country that serve a local community. As one gets to cities, we have hospitals that provide care for a whole city. And Alex and I spent some time with the people from Sheffield, from their children's hospital, and they provide a whole city-wide service, and they are based in the northeast of the city. All the public transport in that city travels into the centre and then back out. So to travel from any of the other quadrants, northwest, southwest, or southeast, means travelling into the city centre and travelling back out again. So for a child to turn up in a clinic, we're talking about a 4 to 5 hour day. 4 to 5 hours out of their school time and 4 to 5 hours out of their parents' work time. And one of the things that we know is that most people work and go to school where they live. So we use local schools, and then we use regional or system-wide or city-wide hospitals. And so what this is doing is increasing or opening up access to those people who live pretty much everywhere. And I think one of the challenges that we're talking about is bringing together social care, NHS, and education has only been achieved in one city, and that's in Manchester. And it's had significant benefits. So what we're talking about is supporting all of that network. We're not saying that children shouldn't be able to visit hospitals, but if you have a long-term condition, and any one of the long-term conditions, usually those children will go to a hospital 4 to 6 times a year. So they'll lose a day's education. And the reference that we made earlier to COVID, those people have lost so much time in school and so much time from education that we think we should try and minimise or ameliorate that.
There's a good point, I think, Steve, that there's a lot of data around the impact of that lost education time. I saw a report which estimated losing a third of a school year over that individual's lifetime would equate to a loss of 3% total career earnings. Now, I don't know how you would relate that to COVID, because it hasn't been quite as cut and dried as, X number of weeks lost. I think there's been some very patchy and some great online learning experiences. I know from my own personal experience with my children, at times that they've had some very good online learning experiences. But if we look at the country as a whole, I think it's true to say that a lot of that education, valuable education time, has been lost or hasn't been as effective as it could have been. So there will no doubt be an impact, and there's a lot, as I said, a lot of data around that.
Can I ask a question around that? How many children have you got?
I have 3 children.
And how many computers have you got in your house?
Oh, that's a great question. So my children are very fortunate that they are provided a laptop by their school, so they have one each, which was very that wasn't the case at the beginning of COVID.
Yeah, but that is perfect, isn't it? That in your house you've got enough computers for each of the children and for each of the adults, and therefore nobody is compromised. You can work at home, your wife can work at home, all your kids can be educated at home. But if we talk about people from lower income groups, they won't necessarily have 5 computers in their house and the Wi-Fi capacity or Wi-Fi speed to support all of this. And so I do think this is particularly a problem in parts of London I've worked in fairly recently, like the southeast of London. If you go somewhere like Romford, which is part of the, I think it's one of the most impoverished parts of London, or Stoke-on-Trent, or any impoverished part of the UK, then you're going to have a really different picture to what you just described.
Yeah, it's interesting. Sorry.
Go ahead.
I was looking at a report from University of Cambridge, and they'd done it on digital poverty, and one of them was saying how a parent has said, well, it's either sort of pay for the Wi-Fi or for their food sort of this month kind of things. I think bringing virtual into the school does really help with digital poverty, having the infrastructure there rather than relying on them to have something at home. It helps that situation, doesn't it?
Yeah. And don't forget, on top of that, and I think that's an incredible reminder for all of us about what it's like to live in poverty rather than to have access to all these things. One of the things you said, Alex, earlier on is there have been some significant gains during COVID. There have been lots and lots of really bad things. But some of the things that we've managed to do really well, we want to keep hold of. And one of those things, as an example, is what the NHS has termed the talk before we walk, so that we can get access to healthcare before we have to get in our car or on our bus or on our train and go to the hospital. And that we can start establishing rapports and relationships, and we can start building support networks before we ever have to walk into a hospital. I also think, Alex, sorry, your children are much more comfortable with digital than the generation before them and the generation before them. And they're quite used to starting relationships that they've never had before, purely digitally, and maintaining them for a number of years before they ever become face-to-face relationships. And I think we forget that.
Yeah, absolutely. And I think we've probably all, whatever sphere of life you're talking about, we've all had that situation where we met, whether it's a friend, a colleague, a co-worker, during COVID, and had never met them face to face. And I think there's a level of relationship that I think there's a glass ceiling in terms of where you can take the relationship where it's only virtual, and being face to face particularly with those younger children and those in education, is a very, very important part of their development journey as a person, as a student, as if you like a citizen. Their development, a lot of the interpersonal connections and relationships, it happens in the playground, to be completely kind of on down to earth about it. It happens when they're working with or collaborating with their fellow students at school or maybe outside of school. That's where a lot of that development is happening. So the point, I think, bringing it back to the kind of theme of today's conversation, the point is, how can we find ways of not taking those students out of that education environment unless we absolutely have to? And I was interested in your comments, Steve, around mental health, and that has been a big topic of conversation because of COVID. Everyone, I think, has felt an impact, and that has it's been widely reported, and I think we've seen the impact of that in many, many different areas. Some of the trusts we're working with have been taking some interesting new approaches to that, including using online as part of that journey with the individual patient. So I know one of the trusts in particular was saying where we've got a mental health, particularly a mental health team, they were expecting to see the patient at least 1 in 3 visits would be physical, but the other 2 could be virtual. If it's a check-in of some sort, if it's just staying in touch to find how things are going, you could actually make that rhythm work. But I'd be interested in hearing kind of your views from a clinical aspect and professional aspect around how you think that might work out, and the benefits to the patient of that.
Well, I think that CAMS, which I know that we now refer to as services for young people, but just to use an easy language, the CAMS service has always been a Cinderella service. It's been funded in a marginalised way. Access to talking therapies has been limited, and so people have been struggling to get face-to-face with people who will support them. And I think that by putting modules or pods in schools, we can allow kids and parents and teachers to very quickly access their primary or principal healthcare provider and improve things, not make things deteriorate.
Yeah, and I think the other thing I'd be interested in is we talked a lot about the education angle and the impact on the student and in the education side, but also the kind of the other side of that coin, if you like, the NHS providers and the possible benefits to NHS providers around this kind of approach. I was just looking at some notes earlier around the current DNA rates, the current attendance rates, and I think something like something like virtual as an overall concept could have a major impact positively on those DNA rates, which ultimately will have a fairly big spin-off and financial benefit throughout the NHS. But this is kind of your wheelhouse, Steve. You could give us a thought or two on that.
Yeah, I think one of the things that's real is around about 1 in 8 people who are meant to go to hospital don't ever turn up. And even if we send them something that says you are seriously ill, so there's a service for bowel cancer screening where people use a stick to stick in their poo and they send it off to a hospital. The hospital or the organisation then contacts them and says, you've got blood, we need to do further tests, please contact us and come and see us. They contact them, they get an appointment. Around about 20% of all of those people who've gone through all of that and been told they have something seriously wrong with them do not turn up. And anything like that which is physical, we need to continue doing physically. But anything that we can do virtually, we need to start increasing the level of service we've got, increasing access to services, and using those things. So why do kids not turn up to health appointments, hospital appointments? It's always that their parents don't take them. And almost everybody on this webinar, and you two guys and me, you would never dream of being told your son, your daughter, your niece or nephew have something seriously wrong with them and then not taking them to hospital. But we forget some people can't afford to take time off work. Some people can't afford to get the bus. And like you said, Alex, Sean earlier, Shane, that we've got people who are making decisions about how to spend their money. And if those people, because they live and work locally and their kids go to school locally, if those parents could walk into a school, could go into a pod with their child, spend 25 minutes on a call with somebody and then go back to work, they'd be much more likely to take their children to hospital. But one of the big challenges that we haven't even thought about yet, there's a program at the minute with Michael Mosley on Channel 4 about who made Britain fat. And it's a really interesting thing. And what it's showing is that something like 1 in 6 children are clinically obese. And we know that for people who have problems with weight, people who have problems with managing their own healthcare, the more availability they have of getting advice and support, the quicker we can intervene and help them. And access to talking therapies, we've talked for 2 decades, I remember, about increasing access to talking therapies or to psychological therapies. But the only way to do that currently is to contact your local provider and mental health trust, to arrange an appointment with an expert and to go in and sit in their office. And I think that if we're going to continue doing that, we're going to miss out. If one considers that 1 in 6 children currently needs some form of support or some form of help, we can't do all of that face to face. There's not enough capacity, there's not enough money, and there aren't enough clinical rooms to let that happen.
And just picking on your earlier point, that where you've got the situation where the student may be joining from school, actually their parent could be joining from their workplace, so they don't even need to come into the school. So instead of an hour and a half out or 2 hours out, you're actually talking about just the time you're in front of that clinician. So 15 minutes, 20 minutes, whatever that is. Yeah. That's your downtime, and the whole thing becomes a lot more accessible, a lot more efficient, and hopefully that's going to majorly impact on the DNA rates as well.
Yeah, and that's a coffee break rather than a morning off. Yeah, good, really good point. Maybe you should sit here.
Good, great conversation. And then kind of looking at some of the other aspects, and I know the questions we often get asked, and maybe Shane, this is something you could comment on. A lot of the trusts we're working with are asking, well, you know, these pods, what do they actually mean in terms of infrastructure? What do we need to provide? How do they work? What's the acoustics? Perhaps you could share some of the common questions you're being asked by the NHS trusts, and some kind of insights around that.
Yeah, definitely. So, I mean, often one of the biggest things, obviously, sort of patient privacy, and in sort of ensuring that the appointment is private, in terms of you can't be heard, and obviously what can't be seen. So, obviously, with our pods, they are you can't hear what is being said, and also if there's glass, then we have a privacy film on that, just to ensure that the patient does have that privacy, which obviously in other areas that doesn't happen. For instance, if the patient just doing it from their phone, if it's still virtual from their phone or something like that, other people can be listening in and obviously hear what's going on. So that's one of the biggest things from an NHS and also from the patient perspective as well. That's quite a big factor. And obviously, if that was within a school or education department, then that obviously can be there to provide a private space for the student to go into to do a call that's away from everywhere else, and almost providing a better area to do it in than if they were at home to do it, or if they did go in for face-to-face with obviously going in, they're meeting lots of other people, and how that's one of the things we talked about, not just with COVID, but how it can transmit viruses. Obviously going into hospital, the more likelihood you are of spreading around things like that, which has obviously been quite a big thing with COVID, but obviously that's normal practice anyway.
That's interesting. And then from a point of view from the kind of infrastructure provision, if I wanted to put, you know, 3 pods into an education or a school or even a hospital environment, what does the building need to provide in terms of how's that pod going to work? What hardware and software are they going to use? Power and data requirements? Yeah,
so I mean, it's really simple. I mean, there's nothing technical about it. In fact, it's a plug and play modular acoustic pod, which can be set up ready for use the next day, and all it needs to power it is a single socket, just to power whatever's in there. So it can be installed basically in any situation, a room or a public space, and obviously if you do want a phone in there, it needs a data cable, but otherwise it is just one power supply, and it can be put up inside any room as a modular piece. So a simple, quick and easy and effective way to create this space for virtual consultations. And I know what the work we have done with trusts, how they've liked the fact that it is quick and easy to install. It's not changing of real estate that has a high expense with it. And one of the things we have done is obviously a lot of trials so that you can pilot it, which is obviously a bigger thing these days, is piloting things to check they work before you go ahead with implementing it properly.
Yeah, that's good. And actually, one thing you mentioned just sparked off a thought that I've noticed with quite a few trusts. There seems to be at the moment, it feels like there's a bigger trend towards phone as opposed to video when we're talking about virtual. And I think there's a real opportunity to actually engage more deeply with that and embrace video for certain types of interaction. And I'm thinking particularly what we were saying earlier about mental health, Steve. I think there's a real value in seeing the patient, in actually having, you know, visual contact. You know, it's not face to face, but I think that is very, very important. But I don't know if you comment on that, Steve.
Well, I trained in mental health, so I'm a mental health nurse, and I spent lots of time in my earlier years working in clinics for people who were living in the community, coming into the hospital for regular checkups and for intervention where necessary. And the first thing that happens in all those situations when someone walks through the door to talk to you is that you do a visual check of them. You make sure they look okay. You make sure they're smiling and happy. You make sure their physical appearance hasn't deteriorated. And it sounds silly, but it's a 1 second, 2 second process that we all do every time we meet people. You can't do it on the phone. So I could be sat talking to you on the phone in scruffy, dirty, filthy environment, and you would never know. If I turn up in front of you and those things are obvious and apparent, you can immediately be guiding a conversation to try to understand why and what's happened and how's it happened. Also, and this sounds really strange, self-harming is a big thing. And we can see when we do video calls, not as well as we can face to face, but we certainly have a much bigger understanding of what the patient's going through when we're looking at them. And most of us over the last 2 years have become really comfortable with looking at people on screen.
Yeah, and I think as human to human interactions, we get a feel for how that person is just by seeing them. As you say, often it's not. It can be just the look, the expression, the look on their face. You can find a lot out about someone, and then that could then guide the direction of that conversation, which you may otherwise have not gone down that route if you were just on the telephone.
Yeah. This sounds like a really silly example. The last webinar we did, you were in New York. And
correct.
It just looked different. You were Mr. Smiley, you were in this sunny office, you had this vista behind you. And it sounds really silly and really odd, but you weren't sat in a small room like you are now. And we make observations and judgments like this all the time, every day.
It's the impact of being.
I'm not suggesting you were gallivanting and doing nothing. I'm just saying it's easy to make those observations.
I think it's the impact of being in Hemel Hempstead. It just has a whole different effect on you.
We talk about something else.
Go ahead, yeah.
Yeah, I live in London, so I understand more about local politics here than anywhere else in the country. But Mayor Khan's office produced a report that said that 18% of all pollution in London comes from NHS appointments. And we know that almost nobody turns up in a hospital for an appointment on their own. Almost everybody brings a spouse, a dependent, a carer, or somebody with them. So we get 2 or 3 people turning up at every appointment. And we know that most people, if they have a car, they will drive rather than use public transport because it's just more reliable, it's quicker, it's easier. And we're aware that on site in the hospital, there's always parking. So one of the things Mayor Khan has desperately tried to do is to get us all in the NHS to reduce the number of journeys to and from hospital. And if you are a parent or a carer and you're turning up to school, collecting your child, taking them to the hospital, and then bringing them back, dropping them to school, and then going back to your workplace, that's 4 journeys for every appointment that we're going to take out.
Absolutely. And just to illustrate that point, we were at a healthcare outpatient event a couple of weeks ago, and Hugh McCurry, who's the National Director of Improvement for NHS England, had some stats behind that story you're talking about there, Steve. So the data he had was 29.3 million avoided appointments between April 2020 and July 2021. 788 million patient travel miles saved.
788 million.
23 million hours of patient time saved, and a reduction of CO2 of just over 161,000 tons. So the carbon emissions and the environmental impact is very much intertwined with the patient benefit. You know, that the lost time or the potential lost time. I think it is very much interlinked, as well as the financial impact for the NHS. And one of the other stats he had was 13 million car parking spaces. saved. So what could that space have been used, you know, if actually we make some long-term structural changes to how the patient interactions are happening, could we actually use some of the real estate that we currently have that's just laid out with parking spaces and turn it into something else, something that's more patient focused?
Yeah, we could, but one of the things we have to remember as a previous estates director or facilities director, that's 13 million earning opportunities lost, because every time somebody drives in my hospital and parks their car, ka-ching, I earn £2.50.
Well, as an occasional patient, I've got the opposite view, Steve.
That's so high in reality. But you know, you could turn that space into clinical space. You could earn more income once we go back onto PPR contracts by seeing more people. So you can certainly offset the loss, and it's much better for it and every other part of society.
Very good, good. Well, I'm conscious of our time, and we're kind of coming down to our last 3 minutes. So maybe Shane, have you got any further thoughts? And we'd love to invite our attendees, whether they're on Teams or on LinkedIn Live, to continue the conversation, either to reach out to one of us directly or to participate in a product trial or visit one of our design centres either in London or in Manchester. Maybe you could share a few thoughts around how people could reconnect following the conversation, Shane.
Yeah, thanks. So I'll put some links in the chat box for we have a trial option for our pod. If you're interested in trialing one of our pods, then I'll put a link in. You can fill out that and we'll be in touch to arrange a trial. Otherwise, you can book in for a demo either virtually or physically at one of our showrooms, and we can arrange a demo of one of our pods to show you how we've used them and what they're like. But just as one thing I was thinking of, Steve, is as what Alex was saying about long term. Obviously, if students or whatever are missing appointments now and they've got long-term conditions, is that really affecting them long term, which in return will mean having to have more appointments long term as well? Don't you say something about that?
It very definitely is affecting them. You know, go back to the stat that Alex came up with earlier. And as for whether it's going to cause us to make more appointments rather than less appointments, I don't think so. I think it's going to help them. It's going to help them improve. It's going to support their condition. We're going to have less crises. So one of the things in mental health services that we haven't talked about are crisis intervention teams. And crisis intervention teams is exactly what it says on the label. If somebody has a really tough time, they contact their support network and their care provider, and they will do something to intervene to try and get past the crisis. And that crisis can be a social crisis like housing, a particular crisis that individual is having, a family crisis. And so I think the more support we give, the less of those episodes and events we're going to have. And I can tell you from my time in mental health, crisis intervention teams are some of the most stretched and challenged teams there are. That's my opinion. Anybody else can have an input.
No, and I could well see and understand why that would be the case. So we've covered a lot. I think we've had some interesting new thoughts and interesting thoughts that we shared. As I mentioned, we'd love to continue the conversation. So if you've joined today, or if you're catching up on this on the LinkedIn stream later on, feel free to reach out to either myself or Shane or Steve. We'd love to continue this conversation. And I think that the challenge that we're facing is this kind of siloed approach to a challenge that is actually impacting on the patient, and by inference, therefore, on each one of those sectors we've spoken about, the healthcare sector and the NHS, the education sector, and also the social care sector. And we'd like to invite you to join together, to join with Spaced, or to try and do everything we can to help improve the patient experience and to ultimately work to come up with a solution that resolves the situation we currently have. And any final thoughts before we close, Steve?
Yeah, one thing quickly, and it's in response to what you just said, Shane. So we all think employers are fair and honest and good. Shane in particular thinks Alex, as his employer, is a really good person. But there are some people around who aren't that good. And one of the things we know is that if you go to your boss and say, again, I need another half day off to take my child to hospital, that some employers are going to use that in a negative way. And so I think there is a risk that people will not take their child to hospital because they fear for their job and they're fearful of their security and their income. And so that using access like we've talked about, with the child being on a pod in school, the parent being on a pod at home, and the provider being on a pod in their world, will help deal with stuff like that, or certainly reduce the number of incidents where that happens.
Yeah, it's a good point and well made, and I think very thought provoking. Perhaps that's one to finish on. But it's a we know it's a real situation, widely reported around 0 hours contracts and all the other things that come with that. So it's something which I think is an additional benefit to some of these other healthcare benefits we've spoken about earlier. So I think that brings us to a conclusion. Thanks everyone, and thanks for joining us very much, Steve. Really appreciate your thoughts and your input, and to Shane, thanks for joining.